Our concluding speaker for this session of What's New in My Specialty will be Dr. Robert Steppacher. He was born and raised in Philadelphia. He grew up enjoying skiing in northeastern Pennsylvania and surfing on the New Jersey shore before coming here to where we actually have real snow and real mountains. He attended college at the University of Colorado, where he received a degree in molecular biology. He attended Hahnemann University School of Medicine, and during his third year of medical school, he discovered his love for vascular surgery. He received general surgical training at the University of Missouri in Kansas City and did a 2-year fellowship in vascular surgery at the University of Massachusetts. He then moved to Ogden and joined the medical staff at McKay-D Hospital. And as part of Mountain Medical Vascular Specialist, he specializes in the treatment of all forms of arterial and venous disease through both traditional surgical methods as well as minimally invasive catheter-based endovascular techniques. He will speak to us on contemporary treatment of aortic aneurysm. Dr. Steppacher.
Yeah, you can give us a second. I'm going to hook up my laptop here so I can show you guys some movies. Just while we're waiting, just so I know, just in general, so I can kind of tailor my speech. How many people here in emergency medicine? Okay. Primary care, internal medicine? Okay. So we'll talk a little bit. This talk is going to be mainly about, who needs to be screened and referred for aneurysms. And then I'll spend the second half of the talk discussing the various methods that I can treat aneurysms and why I may choose one method over the other for each particular patient. If all else fails, jiggle the cable.
Exactly.
Hey, there we go. All right, let's get going. So first, I have nothing to disclose. I have no commercial relationships with any equipment manufacturers. Some of the slides depict one commercial product or another. There's no reason I picked it other than they had good pictures. However, I am a vascular surgeon, which means that I do operate on patients with knives and scalpels and clamps, as well as do catheter-based interventions. So I have a tendency to discuss both approaches. Endovascular devices, whether they're endografts or stents, do have the potential to be abused and placed out of the FDA guidelines. I don't recommend that. I don't do that, and I'm not talking about it here. So I am from Philadelphia, went to college in Colorado, med school at Hahnemann, residency in Kansas City, and fellowship at University of Massachusetts, and now I'm currently living in Ogden. Despite some popular belief, my office is not at McCady Hospital. It's down here behind Walmart. So that's been a source of confusion for some people. But in any case, I do treat the full gamut of vascular disease, including aneurysms, strokes, and peripheral obstructive disease, as well as venous disease, including pulmonary embolisms and varicose veins. I have a very large toolkit in which to address vascular disease, and this allows me to take a tailored approach to each particular patient. Whether it be a bypass graft or a stent, I'm able to evaluate each person as to what they need, and there's actually pretty good data that certain approaches work better for certain anatomical situations. So having someone around who can have access to the full gamut of treatment options is in the benefit of the patients with peripheral vascular disease. So in any case, the objective of this talk, we're going to review the demographics of abdominal aortic aneurysms, and my aim here is to hope to have everyone understand, who is at risk to have this disease. We'll review the risk factors. We'll discuss ultrasound screening for abdominal aortic aneurysms, which is the current evidence-based recommendation for the patient groups with appropriate risk factors. And then we'll discuss the indications and compare methods for abdominal aortic aneurysm repair. So a little bit about the demographics. There's about 40,000 cases of abdominal aortic aneurysm discovered yearly and repaired in the United States. That gives us a prevalence in males over the age of 60 of approximately 2 to 6%. Thus, the incidence of abdominal aortic aneurysm in the adult population in the U.S. is about 2 to 4%. And of this group, rupture occurs in about 1 to 3%. And as you can imagine, this is a highly lethal condition, and the out-of-hospital mortality is about 50%. So 50% of the people who have a ruptured abdominal aortic aneurysm never even make it to the emergency room. And of the 50% that make it, about half of those die. So the overall mortality is somewhere between 70 and 90% in historical studies. I am happy to say that through setting up centers of excellence in aortic surgery and the availability of endovascular repair of ruptured aneurysms, this number is actually going down. So first, let's talk about primary prevention. And as we all remember from medical school, primary prevention means avoiding development of the disease in the first place. So an example of that would be workplace safety regulations, or putting fluoride in the drinking water, or immunizing children. So to really understand how to affect primary prevention in patients with abdominal aortic aneurysms, we have to go over the pathogenesis and the risk factors for developing this disease. So why do we get aneurysms? Well, it's complicated, but it's mostly due to degeneration of the medial collagen, specifically elastin. You are born with a set amount of elastin, which is kind of the rubber band in the media of the artery that holds it together. You develop a little bit more till your early teens, and then that's it. It has a half-life of about 45 years, so for most of us, that's enough to last a lifetime. This, coupled with physical stress, the pulsatile blood flow comes down to the aortic bifurcation. It hits what we call the flow divider, which is where the right and left iliac arteries come off, and that pressure wave gets reflected back to the wall of the infrarenal aorta, thus causing continued weakening, physical stress, and dilatation. So when I say complicated, I mean it's multifactorial, because obviously all of us have a set amount of elastin, all of us have a flow divider, all of us have stress on the wall, not all of us get an aneurysm. So genetics plays a large part. Some people didn't pick their parents carefully and they have a less elastin than others. Hemodynamics, hypertension, the anatomy of the flow divider, and this big group we call other. So infection, especially things like salmonella, which is very common in Southeast Asia. So if you have patients that travel there, or you have immigrant patients, there's something to watch out for. Trauma to the aorta, any type of the arteritises, cystic medial necrosis, or any of the connective tissue disorders such as Marfan's disease. As I was saying before, you are born with a finite amount of elastin. some people have increased activity of MMP9, it's a metalloprotease that degrades the elastin, and unfortunately that falls in the category of you didn't pick your parents carefully. There's not much you can do about treating that. The things we can treat, however, are number 1, smoking, number 2, smoking, and number 3, smoking. Biggest risk factor for developing aneurysm: family history, age, coronary disease, high cholesterol, COPD, and height, although height's probably a marker for Marfan's, are distant 4 through 10. So, does risk factor modification decrease the incidence of abdominal aortic aneurysm? Well, one thing that was tried was placing patients on statins, and this study was done with a fixed dose of simvastatin. And what it showed is that yes, if we do a meta-analysis of 3, fairly, medium-sized trials where they placed everyone on a statin, they found that yes, you do reduce the growth rate of abdominal aortic aneurysm if you place your patient on a statin. I mean, I feel so strongly about having patients on simvastatin that I think they should put it in the drinking water like fluoride. I mean, it decreases stroke, revascularization in both the heart and the legs, heart attacks, and can't say enough about that. Now, smoking. There is obviously a clear link between tobacco abuse and abdominal aortic aneurysms, and this is dose dependent. The more you smoke, the more likely you are to get an aneurysm. So current smokers have a relative risk of 7.6, and ex-smokers have a relative risk of 3. Each year you smoke, you increase your relative risk of developing the AAA by about 4%. However, unlike lung cancer and heart disease, unfortunately, when you quit smoking, your risk does not drop back to baseline over time. So it's felt that smoking is more of an initiating event from the inflammation rather than something that, if it goes away, it stops. The duration of the exposure, rather than the level of exposure, seems to be more important. In other words, a patient who smokes a quarter pack a day or a half a pack a day is at the same risk factor as the patient who smokes 2 packs a day. And the patient who smoked 2 packs a day for 10 years and quit is still at the same risk as the patient who smoked a half a pack a day for 10 years and is at a lower risk than the patient who smoked 2 cigarettes a day for 30 years. So, secondary prevention. This is the main thing that we can affect to help decrease mortality of aneurysms, and this is based on early disease detection, such as a colonoscopy, and then providing intervention to prevent progression of the disease. So examples are mammograms, colonoscopies, early treatment of STDs. Secondary prevention in abdominal aortic aneurysm means ultrasound screening. Safe, non-invasive, quick, no radiation, no contrast. Who should get screened? Well, anyone with risk factors. Who does this mean? Male smokers. So on January 1st, 2007, due to, in no small part, by the efforts of the Society of Vascular Surgery lobbying Congress, the SAVE Act was passed, and this gives you a free one-time ultrasound screening for any man who has smoked more than 100 cigarettes in his entire life, or any man or woman with a family history of abdominal aortic aneurysm. The catch, unfortunately, is that this has to be completed within a certain amount of time enrollment in Medicare. Now, they're going to try to change that, but right now, when you get enrolled in Medicare and you get your introduction to Medicare screening visit, this is a test that needs to be ordered because otherwise it won't get paid for and they're going to be kind of bummed when they get the bill. So, what's the effect of screening? Well, the English looked into this and they randomized patients in their socialized single-payer healthcare system to either being invited to screening or just standard therapy. They randomized almost 70,000 patients in which they invited almost 34,000 patients to have an ultrasound screening. About 80% of these accepted, and out of those 27,000 patients, they detected a little over 1,000 abdominal aortic aneurysms. the bottom line is, in the group that was screened, they had a 53% reduction in aneurysm-related mortality. That's pretty good. I mean, it's hard to find anything that will cut your risk of dying by 50%. So in any case, in the control group, these were the patients who were not screened. They had 92 aneurysms fixed, 10% death rate. In the invited group, they performed 322 surgeries and a death rate of 5%. But what's most important to us is that in emergencies, okay, they had a 41% mortality with 22 deaths in patients who just showed up in the emergency room with a ruptured aneurysm versus 8 deaths and only 27 patients who had an emergent ruptured aneurysm. So let's move on and talk a little about tertiary prevention. This basically means reducing the negative impact of an established disease and restoring function. Basically, this means fixing the aneurysm before it ruptures. Abdominal aortic aneurysms, as you all know, are asymptomatic most of the time. They're found incidentally or by screening. And one of the old surgical adages, it's hard to make an asymptomatic patient better. So when do we fix aneurysms? Well, we try to figure out what's the risk for rupture, and we have a pretty good idea from large surgical studies what the risk of fixing them is. So we make a risk-benefit analysis based on the rupture risk versus their surgical risk, and currently the standard of care is this is based on aneurysm size. Now, one of the first studies was done by Clem Darling, and what he looked at was, there we go. What he looked at were patients who actually died from their aneurysm disease. This is an autopsy study, and what he found was that somewhere between 4 centimeters and 7 centimeters, there's a large increase in the death rate. Another way to look at it is just ask us. So they sent out a survey to all the vascular surgeons in the country, and they asked us, well, what do we think the risk is? So the numbers that we quote our patients in this survey is 20% per year for a 6.5 centimeter aneurysm, 30% per year in a 7.5 centimeter aneurysm. The best numbers, I think, are this trial, ATOM. And what this trial was the thought was that what happens if we fix aneurysms when they're small, less than 4 centimeters, what's going to happen? So what they found in the control arm, the patients that didn't have their small aneurysms fixed, is that it's about almost negligible for less than 4 centimeter aneurysm, about 1.5% for a 4 to 5 centimeter aneurysm, and then this incredible jump to 6.5% per year for a 5 to 6 centimeter aneurysm. So this is why we really use the 5.5 centimeter number as our cutoff to fix an aneurysm. This is the ATOM trial. It randomized 549 patients, and they were randomized to early repair versus watchful waiting. What they found is that if you fix small aneurysms, less than 5 centimeters, you really don't do any good for anyone. There's no difference in survival. And in the non-operative group, there's about a 0.6% rupture risk. In addition, what they found is that the risk of surgery in the small aneurysm group really outweighed the benefit. The risk of dying from the operation was about 5%. This was done in the mid-90s. It was all open surgery. Another way to assess rupture risk is wall stress, and this currently is limited to very large centers. There's a couple places that do this, like the Cleveland Clinic. And basically, they use a very complicated and fancy computer algorithm to measure the fluid dynamics within the aneurysm sac, and then they identify areas that are at risk for rupture. What they found is that if you compare the wall stress technique to just base diameter, it's actually more sensitive and more specific, and this is technology that will probably permeate out into the community in the near future. They also found that freedom from rupture was also better. In other words, the patients who had the wall stress technique had a tendency to get fixed at a more appropriate time, less risk of rupture in the aneurysm. So that's kind of the first half of the talk. It's kind of time to change gears. We can either do a couple questions now or we can save questions to the end. It's up to you guys. Okay. 5 tests, $5. Yes, it is. The technique of screening someone's abdomen for an aneurysm is actually, as far as ultrasound skills go, is fairly easy. So even putting somebody in a van and doing an abdominal aneurysm screen is pretty safe. Now the carotids, that's a different question. The current recommendation from the U.S. Preventive Services Task Force is not to provide preventive carotid screening. It's complicated. The reason is that they feel it's an economic decision. But the short answer to your question is yes. Anybody who has the appropriate risk factors, they need to get under an ultrasound probe. And if that's in the back of a van or in my office or at the hospital, I don't care as long as it happens. Yes, sir. The average growth rate is 1 millimeter a year. So anyone with a 4 centimeter aneurysm over 10 years is going to become a 5 centimeter aneurysm. So the recommendation is for small aneurysms, yearly ultrasound screening. For larger aneurysms, in other words, somebody who is 5 centimeters, they're about to get to 5.5, then every 6 months. I should also mention that, to answer your question, that the other thing we look at in determining who to fix is rate of expansion. So we expect an expansion rate of 1 millimeter per year. If we see an expansion rate of 5 millimeters per year, then we're going to go ahead and fix it, even if it's 4 centimeters. Yes, sir. Sure, absolutely. Let me show you a few pictures. Here, this is a good one. The aneurysms occur, or at least the ones I'm talking about, mostly in the infrarenal aorta. And then getting back to the flow divider, you're going to have the same elastin problem in your entire aorta. That's a biological problem. There's a physical problem here where the pressure waves are coming down the aorta. They're hitting this, which we call the flow divider, and that pressure wave is getting bounced back to the walls, and that's why most aneurysms are infrarenal. Now, thoracic aneurysms have a different set of risk factors. They have a different set of criteria to repair them at 6 centimeters, and a different set of tools to fix them. So I do thoracic aneurysms as well, by the way. So, and I'd be happy to talk to you about them, but that's a whole different talk. So in any case, this is an open repair. I like this one because this was this is what we call a juxtarenal aneurysm. In other words, the aneurysm comes all the way up to the renal arteries. So this graft is sewn in at the level of the renal arteries. This is the left renal vein crossing the aorta. This is an accessory left renal artery that we plugged in. So to do the operation, it's a big cut. I mean, I'm one of the last of the big cut surgeons, okay? And your patient's going to come back and you're going to find an incision from stem to sternum and be like, oh my God. But we make an incision from the xiphoid to the pubic symphysis. We open up the retroperitoneum. We reflect all the bowels to the patient's right. So this is a little piece of the cecum sneaking in. All the small intestine is actually back behind this thing. And then we place clamps, we open the aneurysm sac, and then we just sew in a plastic tube made out of Dacron. This is the way it's been done for 30 years, tried and true, excellent results, 5% mortality, and when you have it this way, you're fixed, you stay fixed. This, if it works, is an endovascular aneurysm repair. So access is made in the groins. We cut down the common femoral arteries in the groins. We introduce a wire followed by an introducer sheath. This is placed up to the level of the renal arteries. We deploy a plastic tube with a spring inside called an aortic endograft. We put a second wire in, what's called the contralateral gate, and then we put a second tube to seal off what we call the contralateral iliac artery, or the contralateral limb. After all the components are in place, we place a balloon inside the stent graft to seal it against the aneurysm wall. And what this effectively does is seals the blood flow from the aneurysm sac and directs it down the iliac artery. So here's the balloon coming in. There's several commercially available devices. For certain ones work better for certain anatomical situations, but in essence, they're all about the same. No, they don't go on blood thinners. I mean, just standard preventive measures. Everyone should be on baby aspirin, statin, ACE inhibitor. That's it. This is a abdominal aortic aneurysm repair. This is what I see when I'm actually doing an endovascular surgery. I see the contrast going in pictures. So what this shows is we've put a wire in, we've put a catheter in, we've identified the renal arteries, the aneurysm sac, and our iliac landing zones. Here, this is after we've deployed the stent graft, and you can see there's still flow in the renals, and the aneurysm sac that was out here is now successfully occluded. Let that run through one more time. It's kind of quick. So all the blood flow is directed down the iliacs. So why choose one or the other? Well, there's criteria. Both approaches have their advantages and disadvantages. So when it comes to anatomy, I can fix anything with a piece of plastic tubing and some Prolene suture and a knife. I mean, you just go in there and you're tailoring the operation to fit the patient's anatomy. With an EVAR, unfortunately, you have to tailor the anatomy to fit the grafts available. Hospital stay. Most of my EVAR patients go home the next day. ICU stay. They go up to CVTU, step-down unit, don't even go to the ICU. Long-term outcomes, well, believe it or not, open surgery is better. 30-day outcomes, EVAR, as you'd imagine, less invasive surgery, less heart attacks, strokes, what have you. So the 30-day outcomes are better. Surveillance, when it's fixed open, it has a tendency to stay fixed. There's really no recommendations for surveillance. EVAR, you're getting a CT scan 1 month, 6 months, 12 months, and then yearly thereafter. Cost, believe it or not, even with anesthesia time, even with the ICU stay, even with the increased hospital stay, it still costs more to do an EVAR. Operator satisfaction, I like doing both. So let's talk a little bit about anatomy, and here are the things we look at. Diameter, well, the aneurysm has to be big enough to warrant fixing, but also the diameter of what we call the neck, which is the distance between the lowest renal artery and the aneurysm sac, that has to be sufficiently small enough to accommodate an endograft. The largest commercially available device is 36 millimeters. You need 20% oversizing, so thus anything bigger than about 32 millimeters, you really need to do open. Angulation, as you can see from this picture, frequently the aorta will come down and make a curve. If this is more than 60 degrees, this graft is likely to unseat, it won't work. Calcium and thrombus. Frequently, the aortic neck or the iliacs or both will have thrombus or calcium in it, and if you put the graft in there and balloon it, bad things happen. Distal fixation, you have to have enough room in the iliac arteries to seal the graft, and access. The vessels, the external iliacs in this point, need to be large enough that I can actually get the device to where I need it. Again, open surgery, I pick a tube off the shelf, I sew it in, you just make what you need to get the case done. All right. I don't have very much time left, but we're going to go through a few trials that compare open versus endovascular approaches to aortic aneurysms. The VA trial was really the first thing that came out, and this was based on their NISQIP data, and they looked at all the EVARs and open repairs that were done in about 50 large VA hospitals. And basically what they found is, as I said, EVAR, as you'd expect, has a lower 30-day mortality than open repair, 3 versus 5%. However, the yearly mortality in this study is about the same. Most of the mortality in the open group is, as you'd expect, is from cardiac complications and pulmonary complications from the laparotomy. This led to actually doing a randomized controlled trial. This was performed in the UK, and what they did is randomize patients who were healthy enough to have an open repair and had correct anatomy to have endovascular repair, and they looked at all-cause mortality, aneurysm-related mortality, their quality of life, postoperative complications, and cost. This is a little bit showing the differences in the groups. They're roughly equal. So what they found is this, is that, again, like the VA study, in the open repair group, initially there's a drop in the 30-day period because you're doing open surgery, people are having heart attacks, they're having problems. But over time, the lines converge. So in other words, at 1 year out, or actually a year and a half out, it doesn't matter. You can have an open repair, you can have an endovascular repair, you're going to have the same mortality rate. And at 4 years out, actually, the EVAR group ends up doing a little bit worse. Freedom from complications. Well, like I said, when you fix something open, it has a tendency to stay fixed. So in open repair, if something's going to happen, it's going to happen up front, but over time, out to 4 years, the reintervention rate is negligible. 6% for a complication other than requiring surgery, and 9% for a complication requiring surgery. However, in EVAR group, that's this line. This means that 40% of these people had to go back to the hospital and have some additional intervention done because the graft wasn't working right, and that's why we get the CT scans. EVAR 2 looked at patients that were unfit for open repair. So this is the same patient population. They had the correct anatomy, however, they're deemed to be too sick to have open surgery. So they randomized them to having an endograft versus observation, and the results of this were striking. Basically what they found out is if somebody's too sick to have open surgery, your all-cause mortality, whether or not you have an endograft, is exactly the same. And frankly, I'm surprised that someone in some healthcare system hasn't picked up on this and saying, no, we're not paying for this anymore if they can't have open surgery. But however, I will say one thing. Your aneurysm-related mortality definitely drops. So if you're an old sick guy and you come in and you do get an endograft, your chances of dying from your aneurysm drop significantly. However, your chances of dying from anything else do not, and that kind of makes sense. The DREAM trial was a similar design. This was done in the Netherlands, and again, patients who could have open surgery or EVAR. And again, same result. Open repair, the early mortality, 30 days, a lot higher. However, at about a year out, the lines converge. So long term, the patients do just the same. Now, freedom for reintervention, again, needing to go back and have something done. Again, the same result. However, a little newer study, better technology. This line is in this line, only 10% of the patients had to go back and have a reintervention versus 40% in the English study. Maybe the Dutch are better at doing it. I don't know. A third trial, this was performed using Medicare discharge data. It's what I call a data mining project. It's done by the folks at the BI Deaconess. They're very good at this. And what they did is use a computer to make synthetic matched cohorts, and then they compared the results of open versus endovascular repair, and basically they found the same thing. And your survival is a little bit better early on with endovascular repair. It becomes the same in this study about 36 months. Your freedom for reintervention is better with open repair. So the last trial I want to go over, and this is relatively recent, this is another VA trial, but unlike the first one, this is a randomized controlled trial. 881 patients, 42 hospitals, open versus endovascular repair. The randomization scheme, very similar to the other trials. You have to be healthy enough to have open surgery. You have to have correct anatomy to have an EVAR. And they looked at the success rate, length of hospital stay, quality of life, erectile dysfunction. These are vets. They're very interested in that. Morbidity and mortality. So 30-day mortality for EVAR, 0.5%. Open, 3%. This is about the numbers I quote my patients when they come in and ask me, hey, doc, am I going to live? The 2-year mortality, however, begins to converge. 7% for EVAR, 9% for open. This is non-significant. So at 2 years out, whatever operation you have, it doesn't make a difference. Procedure time, EVAR is much quicker. I'll be the first to tell you that. Blood loss, less also. Transfusion requirements, less. And ventilator time. Most of the patients that get endovascular repair, they're extubated in the operating room. They go to CVTU and they go home the next day. Hospital stay, well, this is the VA. You stay 3 days if you get a hernia. 7 days for open repair. ICU stay, 1 day for EVAR, 4 days for open. That's honestly about the same. I usually expect 1 or 2 days in the ICU for an open repair, and I don't send patients to the ICU for EVAR at all. No difference, no matter what you do, in major morbidity, success, need for secondary interventions, AAA-related hospitalizations, quality of life, or erectile dysfunction. So to me, what this tells me is we're definitely getting a lot better in placing the grafts, and the technology is getting a lot better. So That's about it. I have to pause for some questions. I just want to say one thing, though, before I leave. EVAR costs more, and it does. It's just because of the cost of the devices. Okay. Thank you.
We'll take just one question now, and then others that have questions, if you'd like to come and...
So make it a good one.
Yeah, make it a good one.
I put the pressure on you guys. Nobody wants to do it. Over here. Yeah, there's actually, that's a good point. There's really good evidence that in women, the rate of rupture based on size is different. Absolutely. However, the studies to confirm that are being performed. They're being performed at the University of Vermont, actually. And as soon as that data is ready for prime time, then that'll probably change our practice patterns in women. Thank you so much.
Thank you. We thank Dr. Steppacher. I have a couple of things to say. First of all, in regard to his presentation, he talked about his large incision. I make a much larger incision and have no complaints from my patients. Also, we apologize for some of the parking difficulties. That's beyond our control, and we've never had that occur before here. There is free parking across the street to the north at the junction parking terraces. I know it's less convenient over there, but we don't have any other way to address that at this moment. You can come earlier tomorrow, like at 6 in the morning, and probably find parking out here, but we do apologize for that inconvenience. We will adjourn this session. The vendors are in the halls. We would encourage you to go visit with the vendors. They help support this meeting financially and are of great assistance to us. We will reconvene. We were supposed to at 10 o'clock, but let's make it about 10:05 or so. I think we'll make up some time on in the next session. And we reconvene in Ballroom B, which is behind this ballroom, because they will be setting this room up for the luncheon. So about 10:05 in Ballroom B. Thank you.